Good evening, everyone. Let's start with today's discussion on your skull base. So I'll just share the screen. So guys, is the audio and video clear? Can I have a thumbs up from anybody? Yeah, thank you, Dr. Saab. Let's start with today's discussion on skull base osteomyelitis. The first question goes, I'll just read it out for you. 55-year-old elderly diabetic patient came with complaints of purulent otorrhea, severe otalgia, and hearing loss. Below is the finding of otoendoscopy, and we have been asked to tell the diagnosis. Then second is most common organism for it, and third is 2 nuclear scans which can be done for the above scan. So I think diagnosis is an easy shot. So I think diagnosis in such a case will be an easy shot. Can somebody take a try for an answer for this question? What is the diagnosis?
Skull base osteomyelitis.
The diagnosis is skull base osteomyelitis. Okay. And second thing is, what is the most common organism for this? So the answer again, without saying, the answer will be Pseudomonas.
Pseudomonas.
And going to the nuclear scans, if we'll say, there are multiple number of scans which are mentioned for this condition. We'll discuss in a brief about them. I'll just let you know. Okay. So the first scan, which is, this is your technetium 99. Okay. Technetium 99M. Okay. And second is your gallium 67 citrate. Third is your indium 111. Yes, Dr. Saab has read everything about it. What's this here? Indium 111 labeled leukocyte. The full name is and after this the fourth one will be SPECT. So the full form of SPECT is also an individual question in itself. It stands for single photon emission computed tomography. Single photon emission computed tomography. Okay, so we'll just see one point for each of them. Please remember the full form of technetium 99 scan. Okay, its the full form is technetium 99 methylene diphosphonate, MDM करके बोलते हैं. So the first thing is that this is 100% sensitive. Okay, but the problem with this is that since this is also positive in malignancy, तो इसकी वजह से क्या होता है, इसकी specificity जो होती है that becomes less. Okay, so this will be one advantage and one disadvantage. And second question which will be there for this technetium 99 scan can be asked is that this cannot differentiate between active infection and bone remodeling. Okay, so these are the 2 points that you have to remember in your technetium 99 scan. Coming to the gallium 67 citrate, basically this is done to monitor
Prognosis.
treatment response. Yeah, prognosis. Okay. So if they ask you directly single question that which is the nuclear scan you will do to monitor treatment response, so your answer should be gallium 67 citrate. Okay. Why? They will ask you why. Because the gallium uptake normalizes with disease resolution. मतलब बीमारी ठीक होगा तो this uptake will also get okay. So you will come to know whether the patient is becoming okay or not. Okay. And third will be your indium 111 labeled leukocyte scintigraphy, and fourth is the SPECT. These 4 names are given in short broad. Okay, so please remember them. So again, coming over here, just see 55-year-old elderly diabetic. I'll just like to take 2 minutes of yours and to lay basically emphasis on this topic. It is very important. First is, just a minute here. So the first thing is your skull base itself is very important, and in skull base the first thing which you should focus upon is your skull base osteomyelitis. Okay, so very likelihood of asking most of the questions from this skull base region, and this pure skull base mein one of the most favorite topic of people is this one, skull base osteomyelitis. And two things extra about this, that this they might also ask you what are the other names for skull base osteomyelitis. Okay, can somebody take a try?
Necrotizing otitis externa.
Necrotizing otitis externa or malignant otitis externa. Okay, this name was given by Chandler. Okay, there is one more name of this thing which is called as pyocutaneous osteomyelitis of temporal bone. This was the first thing. Initially it was called by this name only. Okay, after that Chandler remodeled it, and this name was given by Meltzer and Kehlmann. Normally they don't ask this type of question. This can be asked, that give two other names of the same condition. Okay, generally they don't ask these type of things ki who discovered it types. But DNB being DNB, you have to be ready for all these type of things. ठीक है, तो ये topic को you shouldn't leave any time. कल भी शुरू करेंगे. Start with always revise this topic first. Okay, moving ahead. Now, this is the scan of a patient. They have not mentioned anything about it. Identify the scan, full form of SPECT, mention one advantage and one disadvantage of technetium 99. Okay, so I'll not bog you down with again asking this. I've just taken the short screenshot from Scott Brown itself. This is an indium labeled white cell scan. Okay, so just remember the importance of indium scan. Okay, so answer will be indium 111 labeled leukocyte scintigraphy. The full answer. अगर full 1 marks चाहिए तो you have to answer this. Second, what is the full form of SPECT? We have already seen single photon emission computed tomography. पीछे वाली slide में देखा. Third is mention one advantage and one disadvantage of technetium 99 scan. So the advantage will be that it is a 100% sensitive test. Disadvantage is that its specificity is low because malignancy में भी ये बढ़ जाता है, and it cannot differentiate between active infection and bone remodeling. These are the questions which can come from your skull base osteomyelitis. Apart from these, I would like to take your attention for another 2 minutes, because first thing is the patient is generally an elderly patient. He is immunocompromised. Okay, and जो otolgia होता है, otolgia का there is a classical feature which is being described. The otolgia in skull base osteomyelitis is described as nocturnal, very good, deep, then it is lancinating, sharp shooting pain. Okay, generally more at night, already said, and it is disproportionate to clinical findings. Okay, and otolgia is the most common most common symptom that the patient present with. Second most common symptom will be otorrhea, and what they have mentioned is this is purulent otorrhea. Okay, and generally involved with cranial nerve palsy. Cranial nerve palsies are generally seen along with skull base osteomyelitis. ठीक है, coming ahead. Second question. 50-year-old male came with complaints of otalgia and discharge. No cranial nerve palsy on examination. ठीक है. Given is the MRI scan of the patient. Diagnosis, name the staging used. Okay, so I would like to take your attention to what I have written over here. No cranial nerve palsy. Because cranial nerve palsies are more commonly seen. देखो इस क्वेश्चन का DD दोनों हो सकता है. ठीक है, like as a referent if you will try to answer, your DD of this can be skull base osteomyelitis, or it can also be squamous cell carcinoma of your temporal bone. Okay, but cranial nerve palsies जैसे ही आ जाता है तो your chances of skull base osteomyelitis are more higher. So since they are mentioning there is no cranial nerve palsy, so this goes out. Answer will be squamous cell carcinoma. This language is same is given in Scott Brown itself, the chapter of squamous cell carcinoma. And now give the answer of this. Name the staging used. What is the name of staging? याद है?
Pittsburgh.
Yeah, great. The answer is modified Pittsburgh staging for this. Yeah. Details not important, but you should at least remember what is the name of staging. Please go through the scan also. Right? They can also give it to make it more difficult. They can only give you the scan, MRI scan, and identify what is the condition and some of the associated question. Acha, Pittsburgh staging के अलावा there are two more things which is associated with this. That is called as temporal bone resection. ठीक है, दो टाइप के होते हैं, lateral and external. Both of them, please read about it. I'll send you the screenshot of that at the end of this class in your group. Please go through it. Both the temporal bone resections. Okay. Chalo. Moving ahead. Again, this is an important scan. They might even ask you one thing. They might ask you identify everything. Okay. So I would like to take it the answer over here. Okay. Can somebody see what is A? This one. Is it visible? Can somebody take a try? What is A? This is your pterygomaxillary fissure. Okay. A is your pterygomaxillary fissure. Okay. Now, coming to the easier part. कहाँ गया? B.
Ovale, foramen.
Ovale. Very good. ठीक है. Foramen ovale. No fun in telling what passes through it is MALE. I'll again tell you one thing. In all the exams basically of our Osce pattern, generally there is definitely one question always asked from your skull base foramina. Okay, and every time it happens, they might give you an easier shot. They might give you a scan का section दे सकते हैं. They might ask you to identify what is the structure passing. Identify the what is the foramen over here. They might give you the the syndrome associated with that. Like we'll study in अभी हम पूरे slides में देखेंगे. We'll read about jugular foramen. We'll read about multiple other things. So they can give you the syndromes also. Okay, they might give you the radiology of your skull base. So skull base in itself is important, and definitely you can 100% a question आएगा ही आएगा, whether it's in table or in your Osce's, but it will be there. So if these things should be read in depth. Okay, foramen ovale we all know. Now the C is your carotid artery. Are you all with me? ये देखो, ठीक है. Normally what happens ना, once you get one fixed section, it's very difficult to manipulate. क्योंकि मतलब what is the answer? Normally what we do कि अगर हम लोग डायग्राम पे देखते हैं कि we just a minute here. So normally what happens कि when we search it, when we scroll in diachrome, so we follow up, so we get what is facial nerve, where it is coming around. But once we get a fixed section, so it becomes difficult to answer. Okay, so because of that, you have to practice the important sections. Okay, now coming to the D part. So D will be over the ossicles. Okay. E is your facial nerve, and F is a little bit, I'll say, ectope thing. Petroclival synchondrosis. Okay. Section is from Radiopedia. Okay, I've shared the details in the PDF attached. Okay. So moving ahead. Now, identify the condition. Now, they might give you a history like the patient has been planned for mastoid surgery, mastoid exploration. What thing you should be careful about. Now, please see the scan, and can somebody unmute and answer? I'll make a hint. Chalo. Batao, can somebody see something is wrong?
High-riding jugular bulb.
High-riding jugular bulb. Okay. So this is important. And they might even ask you if you're doing good in your vivas, what are the grades of high-riding jugular bulb? So basically it's of 3 grades. Grade 1, grade 2, grade 3. In grade 1 क्या होता है? It is located less than 1 mm above the lower border of IAM. Okay, in this one it's 1.5 to 2 mm, and here it's more than 3 mm. So it's telling you how likely you are likely to encounter the jugular bulb as you approach the middle ear floor. Okay, images from Scott Brown itself. Now, this is an easy one. Okay, this is an easy one. It's showing you this cholecystoma over here, basically the epitympanic region. Over here, I'll please read about two things. What they can ask you. You see, it's covering the lateral semicircular canal. है ना? So chances of fistula sign being asked with this question are high. So please read about fistula sign. Second, Prozac space. है ना? These things will keep you haunting till you pass your exam. Till you pass your exam, that what is Prozac space, what is fistula sign. So that's why I'll keep on pushing you guys till next 1.5 months that please read about it, it's important. Okay, now just see this scan. It's an easy one. A 24-year-old male came with history of road traffic accident. Now he complains of watery nasal discharge. Okay, on examination, and what you find facial or palsy also. Now identify the condition. And what's the classification of a temporal bone fracture? So other answer so they have given you itself only. What is the condition given over here? So you can see this thing. Like, is everybody able to appreciate this? Right? So this is the fracture line which they are talking about, and there are two types you can classify. See, this is the transverse one, like this. Once you go across the axis, just see. This is the demonstration. Is the case something like that? Okay. And what is the newer one? What they talk about is the otic capsule sparing and otic capsule disrupting. Clinically, on clinical management, DIP doesn't change the course, but for exam going people, it's definitely very important. Okay, so there are two named classification over here. The first one being this, Kelly and Tammy. And second, this is the older one which he used by the name of Ulrich. You can see it's 1926, almost 100 years old. But still we have to learn about them till we pass our exam. Okay, so that also, I also advise you guys, please learn the names, see the scan, identify, and move ahead, how to pass. Okay, sure. Going ahead, now, coming this thing. How the clinical history will go about. 30-year-old female, case of COM left side. You are planning a mastoid surgery for this patient, and this is the HRCT temporal bone scan for the patient. Identify the finding. Now, can somebody take a try? What is the answer?
It's a corner septum.
Good. And the answer is corner septum. So basically, it's a persistent petrosquamous septum. Persistent petrosquamous septum, also called as corner septum. Please see the spelling. Okay? Please see the spelling. This corner is not CORNOR. It's important. Sure. Now, easy one. Okay? Easy breezy type question. Identify the sign. What is SPAL? Please SPAL के लिए just see a GIF or a video on YouTube. Okay? I'll share the link, but please watch it once or twice, that what's happening. They might just give you that see this video and what is being performed 1, 2, 3. Okay, so the answer, what is the sign? Can somebody take a try? Answer repeated times question hai. Kennedy's nipple. Okay, Kennedy's nipple. This is the protuberance of your anterior ethmoid artery. Okay, now, so many a times it is like multiple times we have discussed anterior ethmoid artery. So, but there is a trend nowadays to give a calculation-based question to the exam going student. There will be one statistical question. There will be one calculation-based question. Okay. So this how you can go about. There's something called as anterior lacrimal crest. इससे 24 mm दूरी पे तुम्हारा आएगा एंटीरियर एथमोइडल आर्टरी, ओके, और इससे 12 mm दूर पे आएगा पोस्टीरियर एथमोइडल आर्टरी, और इससे कितना दूरी पे आएगा ऑप्टिक नर्व? 6 mm. ठीक है, तो प्लीज रिमेंबर इट, 24 mm, 12 mm and 6 mm. And what are the landmarks associated? First is your anterior lacrimal crest. 24 mm behind will come your anterior ethmoidal artery, which will be followed by the posterior one, 12 mm behind, and behind it 6 mm will be the your optic nerve. Okay, now this is a very question which was asked 2 sessions back. How to calculate cochlear duct length. ठीक है, so normally what happens कि we ratify it कि in humans this is the normal length of cochlear duct, but in exam what they asked, they gave a HRCT section scan and they asked what is the cochlear length of this patient. Okay, so these are the type of questions, how the trend is changing. We'll share the answer of this in a while. Now identify what spotter of this and what is Delano classification. See, I'm purposefully like bringing sphenoid now in your section. We discussed few things about your frontals. We discussed few things about difference between your anterior ethmoids and the posterior ethmoids. Now few questions about few things about your sphenoid sinus. Welcome, Dr. Saab. Okay, so the answer is, you all know the answer will be Onodi cell. Okay, these septations which you see in your sphenoid sinus, okay, this will be Onodi cell. Delano classification, please remember, it's important. After Delano, the next question will be your Hero's classification. ठीक है, so both of them are very important. They will generally be asked to you in one matter or the other. They might be coming as a direct OSCE based question. What is this? What is this? What is this? Or once like if you get CRS in your exam, AFRS in your exam, and you start when you answer ki sir I'll do FES for the patient. So the things will start ki okay, how will you go for FES? So you should remember ki you shouldn't directly jump upon ki FES se pehle main directly I'll do ulcerectomy. Sir, I would like to evaluate the patient and I will do NCCT PNS for the patient. And as soon as you say ki you will do NCCT PNS, examiner is very likely to ask you, acha, why will you do NCCT PNS? So your answer should be, this is my how I would have gone about it. Sir, it helps as a surgical roadmap for me to help me to encounter the structures which I'll be coming around. और जैसे ही वो ऐसे बोलेगा, वो तुमको पूछेगा, he'll ask you कि what are you looking in the NCCT PNS? So you have to tell him, sir, I look at the attachment of the uncinate. Then you go inside, sir, I will look at the Kiros classification, and just look at the examiner and wait. He will ask you कि भैया what is Kiros classification? Don't directly say कि sir I will be looking at type 2 है कि नहीं है, type 3 है कि नहीं है. Now just give him time to answer. So that's why I keep on telling you, giving Viva is an art. Try to develop it. Tell the examiner that you have read the topic, you know the topic. Whether you have not read in depth, that's fair enough. 3 hours of exam cannot judge what you have done in 3 years. But you should be smart enough to answer few questions so that examiner thinks कि हाँ इसको मैं 50% से ज़्यादा marks देगा. ठीक है? So this is how you can. This question is not only about कि you should know about Delano's classification. Nah, this is how you should apply this knowledge if it comes in your Viva. If you happen to get a case of CRS, happen to get a case of AFRS, pull the examiner towards FES. If he asks you kya karega, pull him where you know the things. Okay, don't get stuck about in things which you don't know. Okay, chalo, moving ahead. Okay, so these are the types of your Kiros classification. Now coming to the few of the structures which important things which they pass about. Identify the highlighted structure. What structures passes through it? What is Wernicke syndrome? Answer is easy. Anybody has any confusion in this answer? I don't think anybody, everybody knows it. So it's a jugular fossa. What structure passes through it? Let me divide it as per your Scott Brown. This is your pars nervosa or pars vascularis. Nervosa, it is nervous. So nervous होने की वजह से it becomes small. This is small and anteromedial. and what all passes through it? This is basically your inferior petrosal sinus, cavernous sinus, IJV, and 9th cranial nerve, right? And over here, what will pass? 10th and 11th cranial nerve, and then jugular bulb will be there. We'll just see about what is Wernicke syndrome and what are things are associated with Wernicke syndrome. Just see this scan. Okay, the CT counterpart of the same question. They might, what they will do is they will hide this thing, है ना? They will hide this thing, they'll hide this thing, they'll hide this thing, A, B, C, D, है ना? And they'll ask you what is A, what is B, what is C, what is D. So this is a scan which you should remember along with the jugular fossa. Okay, so what basically happens in your Wernicke? There is problem of your 9th, 10th, and 11th cranial nerve. So if your 9th nerve goes, what will happen? There will be loss of taste in your posterior 1/3 of tongue. ठीक है, 10th हो जाएगा, 10th चला गया तो there will be gag reflex का loss, there will be loss of gag reflex. And 11th is basically when 11th goes, so there will be your shoulder stroking will be affected, and SCM will be affected. Acha, there are two other syndromes apart from your Wernicke. You should just remember the name of them. The name are Willaret and Collet-Seekert. Okay, all this table is given in your Scott Brown. Okay, please go through it. Again, coming to this important section. Okay, so please go through it, how the structures pass through the jugular foramen. Okay. Acha, this itself can come as a independent Osce. Okay, so it doesn't happen that कि jugular foramen पढ़ के आधा छोड़ना है, नहीं. Please go A to Z of this thing. It's important. Here, all the things like what all foramens are there, what all passes through it. Just remember them. Okay. This somehow or the other, Dr. Saab, if you have not ratified it till now, please remember it. Second thing, what I'll tell you, I have seen both the sides. Like they might in the Viva, they can give you like simply they can ask you, but if you are unlucky that if you happen to get a osteology table, है ना, उसमें they will be giving you this skull base, है ना, and you will be asked to tell कि अच्छा what if this, what if this, what if this, what if this, what if foramen magnum तो कोई नहीं पूछता आजकल. They'll definitely make you hang around over this. Okay, so in case if you have not gone in detail about skull base anatomy, please go through it once again. I'll share you a video of this Dr. Virendra Karyan. He like thoda sa it is lengthy, but your foramens will get clear. And if you, I'll request कि Viva से पहले एक बार get the hang of that hard bone. Osteology का bone just take in your hand, just go through you. I know you all remember what all passes there, but the exam stress is likely to make you mistake. They in what stress they might even they put Jobson horn probe in one foramen and tell what is this, and with that sad face you are likely to make mistake. So please go through it once again. Okay, coming to this question, what are the boundaries of superior orbital fissure? Okay, and what is Rochon-Duvignet syndrome? Okay, so over here again, the anatomy of sphenoid bone, which we discussed, is coming into importance. Okay, revise it once again. This is your superior orbital fissure, and I'll not take much of your time. If you know the answer, it's good enough. अगर नहीं है तो please read about it. The whole idea of this session is not to tell you कि ये है. It's to sensitize you that you must have read jugular fossa multiple number of times. There's no doubt about it. You must have read superior orbital fissure multiple number of times. But to sensitize की question इस तरीके से पूछा जाएगा. This is how they'll frame a question. This is how your mind will start working. Okay, so these are the boundaries and these are the contents. Please ratify it. That you shouldn't make any mistake over here. Okay, and superior orbital fissure syndrome is also known as Rochon-Duvignet syndrome. Okay, so please remember it. Okay. Chalo. Over here, there was one more question over here. See, there's something called as orbital syndrome, apex syndrome also. In this, there is ophthalmoplegia, there is ptosis, fixed pupil, and vision loss. So this is the difference between superior orbital fissure syndrome and orbital apex syndrome. That in orbital apex, there is loss of vision. जबकि इसमें विजन इज नॉर्मल. ओके, Okay, so this can be a single-handed question. They might give you something of this sort, anatomical question or a radiological question. They'll ask you what is Rochon-Duvignet syndrome, what are the contents, what is the syndrome, and give one difference between superior orbital fissure syndrome and orbital apex syndrome. Okay, so please don't make a mistake. This is the only one difference which you have to learn about it. Okay, we saw these syndromes in a slide before: Collet-Sickert syndrome, Wernet, and Villaret. Okay, this we saw in detail. Over here you can see both of the above also. Okay, no fun in telling. Already asked question. Identify the diagnosis sign. What is the contrast? Chalo, can somebody unmute and take an answer?
Acoustic neuroma.
Yes, the answer is vestibular schwannoma. ठीक है? If you are happening to answer it, answer vestibular schwannoma rather than acoustic neuroma. Okay. Second thing is the sign is called as ice cream cone sign. The contrast which you use for them is gadolinium contrast. Okay. Now there is a named curve over here which we use in the vestibular your acoustic vestibular schwannoma. The name of this curve is Nelson-Allen curve. There are two curves which are important for an ENT resident for exam going purpose. One is Nelson-Allen curve और एक बार आप जब पढ़ेंगे तो there is something called as Kaplan-Meier curve.
Kaplan-Meier.
ठीक है, both of them have no. This Kaplan-Meier I have seen in the question. Nelson-Allen I have not seen it till now, yet to see. But don't be surprised. It's a name given in Scott bound itself. Typical graph is there, and they have given a name of this curve. So please go through it. You'll get 1 mark for it. Okay. So we are interested to get marks till you cross that 150 marks. Pass hona hai. Okay. Chalo, moving ahead. Repeated question. Once you move ahead from your vestibular schwannoma, you'll add up into this. Identify the device. SRS is recommended for what size of tumor? What is pseudoprogression? Okay. I think third time pseudoprogression is coming in front of your eyes. So the device goes as your fiber knife. Okay. And we all know that size is less than 3 centimeter. We use it. Second question can come: what will happen if you use SRS for a tumor bigger that size? So obstructive hydrocephalus can occur. Okay, and what is pseudoprogression? It's mentioned over here. There's something. 2 questions will again come after this. There will be RION, radiation-induced optic neuropathy. Please remember it. Cyber knife versus gamma knife. And SRS versus SRT. ठीक है? So this is how, once you see this picture or once you see vestibular schwannoma, all these things should go in front of your mind. Okay, just see this drug. Bevacizumab, 100 mg / 4 ml, and this is a MRI scan given to you in front of you. I hope you will appreciate this. Bilateral CP angle tumor. Okay, so bilateral CP angle tumor. So your diagnosis goes in favor of your NF2. And this drug bevacizumab is used in treatment of your NF2. There are multiple other uses also, but over here we'll be just focusing upon NF2. So what is the mechanism of action of this drug? Can somebody unmute and take a try? Yeah, great. And जब exam में लिखेंगे तो please don't write VEGF inhibitor. You should write full form. Vascular endothelial, yes, growth factor. ठीक है, यहाँ पे आप ब्रैकेट में लिख दें, चलेगा. ठीक है, you have to tell examiner that you know the answer. Please give me marks. Okay, condition NF2 हो गया. Screening protocol for NF2 we have seen it. This is a screening protocol. MRI से screen करेंगे, and for every 2 years for those who are under 20 and 3 years for those who are over 20 years of age. Please go through it once again. Okay, so one more section of jugular foramen again coming into play. Jugular foramen is important Dr. Saab, है ना? Please go through it multiple number of times. It's likely कि ये चीज भूलने वाला चीज है. ठीक है? So it's given in Scott Brown, and the numbering can very well be managed as A, B, C, D, and you might be asked to tell what are the what is A, what is B, what is C, and there are named syndromes associated. Please remember the names: Wernet, Villaret, Collet-Sickert. ठीक है? So these are the entire names apart from Scott Brown. जो 3-4 और नाम थे वो we have included over here. Let's see if you want to go through it. Okay, so over here till here, though I'll finish the discussion which I had brought with me. 2-3 things which you should remember. First, skull base osteomyelitis, please read in depth. Okay, hardly there will be 3 or 4 questions which can come. Okay, squamous cell carcinoma, 2 questions will be there. First will be the name of the staging, that is your Pittsburgh staging. Second will be your temporal bone resection, both the types you have to read about. And third will be skull base ka foramina. Okay, everything about it, hard bone ka anatomy, soft bone ka radiological features, syndrome, structures passing, and any syndrome if associated with it. And after that, once you go through it, you should start with your jugular foramen, then superior orbital fissure. Okay, these 2 things are important. Please go through it. अब इसके बाद जो subsequent इसका class होगा skull base, I will take in depth, है ना? Repeat जो daily questions है, they will be more directed towards the skull base focusing questions. Revise it again and again. Okay. So any doubt which you are having, which you like, any point which you like to share, anything from your side? Nothing? Okay. ठीक है. If there's nothing else, so we'll take a break, and we'll meet on next class. I'll update you on Friday. I tried to make the schedule in such a way that holidays oblique these events are coming, we'll try to take a class one day or prior. There's no fun in studying when your all friends are enjoying outside. Okay, so you should enjoy also, and like be ready to get the result anytime. Like the people who are waiting for theory, so make your ignition mode ready. After the result comes, they will take a week or time, or say 10 days of time to give you that date of exam. Abhi still they'll not give you the date of exam. They Hindi में बोलते हैं तड़पाते हैं. So you actually get so much eager कि when is my practical gonna happen? When will I get my center? And you will be again surprised that is a problem which comes with DNB, that your center, you'll be surprised that you are doing your PG from Kolkata supposedly, and you get your center far away in Telangana. So all those things you will have to manage. We'll keep on messaging you that how to go about it, how to book ticket, like where all to stay, those all tips we'll keep on discussing. Okay, so as far as all these things are concerned, please keep on reading half an hour daily. That will be more than enough. I'll not say कि 6 घंटा पढ़ो, because nobody reads 6 घंटा, है ना? So keep on reading little bit, and 5-10 OSCE daily, keep solving. And any point you get stuck, any problem, please drop me a message. I'll get back to you. Chalo, all the best. Bye. Good night and happy Christmas. Merry Christmas.